Hi and welcome to the Conceive Baby discussion today. Today I'm thrilled to be speaking with two of Australia's leading IVF and fertility specialists who will really be delving deeper into the IVF process for us. We'll be explaining exactly what's involved, why it can fail, and what you can do to increase your chances of success and stay positive during the IVF process. Now, for those of you who haven't joined us before, my name's Tasha Jennings, founder of Conceive Baby. I'm a naturopath, nutritionist, natural fertility specialist, and author of the Vitamins Guide and the Fertility Diet, as well as an expert contributor to many major media publications. I'm also the director of Zycia. Now, Zycia means life and specialises in premium nutritional supplementation to promote and support life in its earliest stages. And as many of you who are part of the Conceive Baby community would know, I'm passionate about helping couples fall pregnant and have happy, healthy babies. And my aim for conceivebaby.com.au is to really bring together a team of specialists across all aspects of fertility and preconception health to bring you qualified expert information to help you achieve your baby dreams. And I'm speaking today with two valued members of that Conceive Baby expert panel, as Dr. David Knight and Dr. Sonya Jessup of Demeter Fertility. Now, Dr. Jessup is an experienced fertility specialist and gynecologist who has studied and worked in reproductive medicine for the past decade. Sonya has been through IVF herself and works to create a positive, low-stress, sustainable approach to fertility treatment with success rates significantly above the national average. Now, Dr. Knight is a medical director, fertility specialist, obstetrician and gynecologist, and is a pioneer of mild ovarian stimulation in Australia. Dr. Knight achieved the first Australian pregnancy using the double stimulation approach and has developed the Over 40s program, which is really an extension of his 2 decades of work with the effects of diet and supplements. Committed to a patient-centred approach, he's a leader of the state-of-the-art clinic that continually strives to maximise patient wellbeing. And Dr. Knight is particularly proud of the success rates that he and the Demeter Fertility team are able to achieve, particularly in women over 40. Now, Dr. Knight is also a highly sought-after media spokesperson for the IVF and the fertility industry, and it's wonderful to be chatting with them both today. And we firstly have Sonya, because David is busy with an embryo at the moment, so we've been told. So welcome, Sonya, initially.
Hello.
Look, it's really lovely to have you on board. And as I said, what we'd love to do today is to delve deeper into the IVF process. I think we know about the egg and the sperm going together, but obviously there's a lot of other factors involved. Can we start there with what really is involved in the IVF process?
Okay, so the in vitro fertilization process, in its most simple sense, just means fertilizing an egg outside the body. So for a start, you could potentially do IVF with monitoring a woman's natural egg, the one that she makes each month, collecting the egg with a needle that goes on top of a vaginal probe through the vagina, fertilizing the egg and putting it back. So in that way, there'd be no extra injections, no extra problems except for the egg collection. The issue is, if you do it that way, the body has a way of releasing that egg whenever it wants to. So you could plan to do an egg collection, you'd release the egg naturally, perhaps the night before. So it's very unpredictable. Also, if you get an egg, you might find that that egg is not a mature egg, or it's not a good quality egg, and therefore you'd have to go and start the whole process again. It's for that reason that we give injections going through an IVF cycle. It's to maximize getting an egg or 2 or 3 or 5 that we can use to make the cycle slightly more efficient, give you more chances of getting an egg that fertilizes that will go back and make a baby.
Right.
Okay.
Yep.
There are a number of ways of starting an IVF cycle. In the old days, people used to take injections for several weeks before starting, or the pill before starting. But these days, we've realized that the majority of the time, you can start with a woman's period. So basically, at the beginning of a period cycle, the lining of the womb should be thin because a woman's just had a bleed, and there shouldn't be any cysts on the ovaries. What we are looking for is the little immature antral follicles that are there to stimulate those follicles to do IVF. Now, some people think that they are using up their eggs more quickly in an IVF cycle, but that's not the case. Each month, about 30 little immature eggs begin to develop up, and one of those eggs becomes the most dominant, and all those others die off. What we're doing in the IVF process is that we're giving slightly bigger doses of the FSH hormone, which the body produces anyway, so that instead of one egg coming through, we get more. We may get 3, 5, 7, 10. These are eggs that we're going to die off anyway, so we're not using up the eggs at any greater rate. You don't go through menopause at an any earlier rate. You're just creating some more eggs that you can use for an IVF cycle. So the hormones at the beginning of an IVF cycle are designed to bring more eggs through than usual. They stimulate the ovaries. They don't normally cause too many problems for the woman at the beginning of the cycle, but as those eggs develop, the estrogen level is higher. So in a normal ovulatory cycle, a mature egg will have about 1,000, let's call them units of estrogen. If you have 5 eggs, your estrogen level may be 5,000. So obviously there is an increased level of estrogen, and sometimes women detect that in terms of their mood or the way they're feeling.
Yep.
When those eggs get to a certain size, and it's normally about 14 millimeters, they run the risk of the body all of a sudden creating a rise in the LH hormone, which makes those eggs release. Nobody wants to go through all the process and turn up to an egg collection and find that all the eggs are gone. Mm-hmm. So we start a second injection. Usually we use orgalutrin, but it's designed to stop the eggs accidentally releasing until we're ready for them to release. The ultrasound scans are just to monitor the growth of the eggs so that we can see how many we've got and how quickly they are growing. When those eggs, or the largest of those eggs, are about 17 or 18 millimeters, we give a special injection at nighttime that matures the eggs. In our clinic, we set that at about 36 hours. So if you give an injection at 8 o'clock at night, not the following day, but the day after that in the morning, at about the same time, 8 o'clock, a trigger injection at night, 8 o'clock in the morning, those eggs are almost ready to release naturally. Then we collect them just before that time so that we get nice mature eggs.
Excellent. Yeah.
So once we've got those eggs and we've given the trigger injection, there is a bit of a leeway. You can probably collect eggs between 36 and 38 hours later. 36 hours is easier to manage because most people understand an 8 o'clock at night injection and an 8 o'clock in the morning egg collection, and it means that we don't confuse the collections times as frequently. When you collect those eggs, it's done through a transvaginal ultrasound. So in the same way that women have monitoring of their ovaries or up there and lining of the womb, there's a little attachment that goes on top of the probe. The top of the vagina and the ovary are very close to each other, about 0.5 centimetre to 1 centimetre. In our clinic, we often do this under local anaesthetic because we're very experienced at doing this. And most women tolerate this extremely well. Sometimes we give them a dose of endone or something just to make them relaxed. But basically, with a little bit of local anaesthetic, you can get the needle into the ovary and just start to drain those follicles. It feels, obviously the local stings a little bit, and when the needle goes into the ovaries feel a bit bruised. They're large, so they feel a little bit uncomfortable. But it's not, many women talk to me the whole way through the cycle and laugh and talk with their husbands. So even through the egg collection, it's not a difficult problem. There are a few women who have very difficult ovaries. They're stuck behind the uterus, or they've got lots, or they just are not used to that feeling of something being inside the uterus, such as a probe. And for those women, we do it under general anaesthetic when they're sound asleep. Once we've got those eggs, we then need some sperm to fertilise the eggs. So either the husband provides some sperm on the day, or for women using donor sperm, or for the donor sperm, and we fertilise the eggs. Now, there are 2 ways of fertilising those eggs. One way is to get a normal fresh sperm sample and in certain concentrations put that sperm with the eggs. And we need about 20,000 sperm around each egg to create a reaction that it's one egg and one sperm inside. So the sperm has to be of a reasonable number, and it needs to have good motility for that to happen. Now, if the sperm sample is not so good, the other way that we can fertilize those eggs is to get one sperm, make a little hole in each egg, and put one sperm inside each egg. And that's called ICSI, intracytoplasmic sperm injection. ICSI doesn't improve on normal fertilization. So if you've got normal eggs and normal sperm, you should get about 75% of those eggs fertilized normally, whether you do normal IVF or whether you do ICSI. If the sperm is not of good quality or low numbers, however, you can get a situation where you don't get any eggs fertilized. And yet with ICSI, you should bring it back up to that 75% number. Yeah. Once that we have the fertilized eggs and we're growing those on, we put those embryos back at a day, some day after the egg collection. Now, there are units in Australia that do all their embryo transfers on day 2, some do day 3, some do day 4, and some do day 5. So we know that you can put these embryos back at any stage, and a good quality embryo should have a good chance of making a baby if it's genetically normal, no matter when you put it back. However, if you get quite a few eggs, we would like to grow them on a bit further so that we know which embryos are going to make a blastocyst or a more advanced embryo, because those eggs have a slightly higher chance, once they've made a blastocyst, of maintaining a pregnancy. For women that only get a few eggs, however, or one egg, sometimes we will put them back earlier because any given egg or embryo actually prefers to go back in the body a little bit earlier. So this is why there's some variation with what day that embryos go back. Yep. The other thing with an IVF cycle is when you've got more than one follicle, in a normal, fresh, natural period cycle, that egg that releases where the follicle that it comes from makes progesterone. Now, in an IVF process, that process doesn't work quite as well, and it's for that reason that women take progesterone pessaries or injections just to make sure there's enough progesterone for the IVF cycle. So once those embryos go back on day 3, 4, or 5.
Hi, David. Welcome, David. We're still talking about the IVF process.
Fantastic.
You get back about 10 days after a blastocyst goes back, you find out whether you're pregnant. If you're pregnant, fantastic. If you're not pregnant, you may have frozen embryos that were able to be frozen at day 3, 4, or 5. And in the next cycle, you don't need to collect all those eggs again. You can wait till a woman ovulates normally, and a week later put another embryo back. And in that situation, you don't need the injections because you're not trying to get more than one egg, and you don't need the pessaries because in a natural cycle with one egg, that corpus luteum provides all the progesterone for that cycle.
Excellent. Look, that was great information. I think it's really clarified what's involved, and really IVF is just doing what the body is doing naturally, but helping to regulate it more efficiently so we can actually get the results we're looking for.
Absolutely.
I try and look at it like maximising all the potential that's there at the time. And I think it's also really important not to do extra things to it in trying to get eggs and trying to get sperm that can actually make them worse.
Yeah.
Because we all know that if you use too much of anything, you get worse outcomes, not better outcomes.
Yeah, I think that's good for people to know, because I think we all know that there are injections involved, there's pessaries involved, there's hormones involved, but knowing that it's just something to work alongside the body and complement and, yeah, as you said, maximise and enhance what's already happening, and that it's not as intrusive as some people may believe, as Sonya discussed about the egg collection.
Oh, I think it's also important to realise there's lots of different ways of doing it. So some places, some clinics will not quite get the idea right, and are trying to get too many eggs, so there'll be too many hormones. So it really is, this is a quality issue, not a quantity issue.
I think knowing those things, I guess it helps empower people to do ask those questions of their fertility specialists about how it's done, how the egg collection is done. As you said, there are a lot of different methods that can be used. And I guess now while we've got you here, David, what we wanted to talk about, that's how it works, that's how the process works. We enhance what's already happening in the body to collect as many viable eggs as possible. And there was different methods of connecting that with the sperm and putting that back. So if we've got the egg and the sperm together, we've got the embryo created, why can that fail? Why does it not continue after that in some people?
Well, in fact, most of the time, putting an egg and a sperm together doesn't give a baby, which is really cool if you pick someone up at the pub, but not cool if you're trying to have a baby.
Yeah.
It's not as if we've got control over it. I mean, one of the things that happens is that the body's doing this stuff of its own accord.
Yeah.
So to understand why just putting an egg and a sperm together and making an embryo doesn't give you a baby, it's important to understand how the body works. Specifically, it's really about the quality of the egg. Males are really just a very complicated design for delivering a small amount of DNA, whereas everything that makes up a person, a new person, apart from that little bit of DNA from the sperm, comes from the egg. And we know that. I have my mother's, for example, my mother's mitochondria in me, and Sonya has her mums in there, and you have your mums in there. So that's all part of the original egg. The ovary will lose, and about 1,000 to 2,000 eggs a month will die. And in the ovary, when it grows eggs in waves. And if a wave is coming through and the hormones are right, then that wave will begin to grow. All the other waves, because of those hormones, go away. And the body never sees them and they die. In that wave that starts to grow, there could be anything between 1 and 20 eggs. And those eggs begin to grow under the hormones released by the body. And then over about 2 weeks, one of those eggs works more competently and is more functional than the other eggs, and it becomes the dominant follicle, and that's the one the body releases. In other words, there's an inbuilt natural ability of the body to choose the best egg in the wave that's growing to be released. Okay, so when a woman is ovulating every month, the best egg that's there that month that responds is the one that the body releases. Now, clearly we know from just looking around us in the world that people have a lot of intercourse, but they don't get pregnant and have a baby every month that they're having intercourse. So there's something stopping that from happening, and basically it's because the best egg most months, while it's the best egg, isn't good enough to make a baby. There's some other things in there that aren't working. So it's good enough to make hormones. You know, sometimes it's good enough to conceive and implant, but most pregnancies are lost at around about the time of the period. And of the pregnancies we see, 25% of them end in miscarriage. These are all eggs that, these eggs good enough to make a pregnancy, but not good enough to make a baby.
Yeah.
So that's why we don't get, you know, women don't get pregnant every month when they have intercourse. It's also why they don't get pregnant every month that they have an IVF cycle and collect a group of eggs. Because we've got the best egg they're making that month. And if we get more than one, we've got the second best and third best and fourth best, fifth best. And if the average number of eggs collected in Australia is 15, so we've got the best all the way down to the 15th best egg. Okay, right. The bottom line is if the best egg isn't good enough to make a baby, we already know about the rest of them and they're not good enough either. Yep. Okay, so we do know that a lot of these eggs will still make embryos, and so people can get a lot of embryos. We think that every embryo is a shot. But, you know, from that explanation, it's clearly that it's not. What we want to know is whether the best egg's good enough to make a baby.
Yep, yep.
Now, for most women who undertake IVF, and these are worldwide figures, about 75% of, or 75 out of 100 women doing a cycle won't have an egg that's good enough to make a baby. Yeah. Worldwide figures. So this is not, you know, people making up. This is how humans work. 25% of women will get a baby out of that. And down the bottom, about 1 or 2% will have more than one egg in that group that's good enough to make a baby. Because if, let's see, logic, if one egg is good enough to make a baby, it doesn't tell us how good the next best egg is. And there are some women who may have 1, 2, 3 eggs in one group of eggs that can make babies, generally if they're in their early 20s. We don't see it very often, but unfortunately, because we know that, all the other women who do IVF also get hormones. Now, we need to change how we think about it, because, you know, it'd be fantastic if we were in that group.
Yeah.
Most of the time, that's not going to happen. In fact, most of the time, we're going to be in the big group. So we just need to keep doing it until we just, fortunately, get an egg collection in a month where the best egg is going to give us what we want.
Yeah. Yeah, exactly. So basically what you're saying is if the first cycle fails, you're not a failure. You may have another way with better eggs next time, and you will get a successful outcome next time. So, yeah.
That's right.
I think I'll just jump in there with my own personal experience. When I was in my early 30s, I had 4 children, and pretty quickly, within a month or 2, pregnant, so very easy to conceive. Now, when I was 41 and nearly 42 doing IVF, I had to do 3 IVF cycles, made 6 what looked like pretty good quality embryos. They were blastocysts. And
only one was good quality.
I had to put back five embryos and not get pregnant before I put back 1 that made a baby. So this is the same person, the same uterus, but it shows the effects of the age of the eggs. So even in the same person, waiting from 31 to 41 to try and get pregnant meant that I had to put, well, you know, there were a lot more eggs that weren't, even though they were good enough to make a blastocyst, they weren't good enough to make a baby. And that certainly was a bit of an eye-opener for me, how much the age does affect the quality of the eggs.
Yeah, absolutely. I think there is also a perception that if you have an embryo, you have a baby, which, as you said, it might be healthy enough to create a pregnancy, but not a sustainable pregnancy to carry a baby. And so obviously...
Having said that, though, having got the baby, completely healthy, happy, little, delightful baby, so it doesn't seem to affect the quality of the child. Our youngest one's a delight.
Well, I mean, we talked about, obviously, age there is a great impact on the health of our eggs, and that is something we unfortunately can't change. What are the factors that you suggest people do, I guess, enhance about themselves? What can we do aside from age, which we can't change, that we can change about creating the healthiest egg possible and helping get that great collection?
I think that if I had my way, everyone would have a fertility workup when they were relatively young to check what's going on, make sure that they've got enough eggs, that they will be able to conceive in their 30s, make sure that their tubes aren't damaged, make sure that if they've got endometriosis, it's looked after with medications or progesterones or the pill. Because as you know, that the ability to give extra supplementations and antioxidants makes a huge difference to the quality of the eggs that are coming through. Yeah. However, if you're in a group of people that for some reason your partner's got very few sperm or your tubes are blocked, then you're not going to get pregnant even if you've got the healthiest, best quality diet, because the egg and the sperm can't get together. Yeah. And I think if people know that the basics are working well, they have eggs, the tubes are open, their partners have got sperm, they have, and it's very worthwhile then spending time on getting their diets right, making sure they're as healthy as possible. If you're not in that group, however, you still have to work on your diet and making sure that you're fit and healthy, but you will know that you need to go down the IVF path, and you may as well get started with that earlier rather than later, because you've got more chance of being successful.
If you've got a partner.
If you've got a partner, yeah. If you've got a partner, you've got more chance of doing IVF when you're 30 than trying naturally for 6 or 7 years and then finding that the tubes are blocked or your partner's got no sperm, and that 7-year delay has actually decreased your chance of getting pregnant. So I think making sure that everything's working is a good starting point, and then women can focus on, and their partners, on getting everything as good as it can possibly be. But I think the starting point of making sure that the basics are there is pretty important.
One of the things that we don't have a lot of control over in our lives is how our lives turn out. We think we do. There are a lot of people coming through and say, well, it's all well and good, but I can't find a man that I like, and the ones that like me, I don't seem to, enjoy. So when people have the opportunity, it often doesn't occur in today's society until often into their 30s, sometimes their 40s, or second partnerships and things like this. I think there's some quite specific things as people get to the older end of the reproductive age group that can be helpful in regard to improving their chances of conceiving. One of the biggest things is people's weight. The problem, of course, with that is the studies are invariably showing that it's extraordinarily difficult to lose weight and then maintain it over a long period of time. And if people do that, they tend to do the old yo-yo stuff, and 10 years later, they're about the same weight as they were. And people put a lot of pressure on for women, for example, to go away, lose 20 kilos and come back. And the reality is that just doesn't happen. You may as well talk to them sensibly about that, or talk to them about gastric sleeve surgery, which does work, but is a different tack. I sort of talk generally very much about that. I don't place a lot of emphasis on it because it doesn't work very much and people get really uptight about it. However, I think there are some significant things that we can do aside from that, especially from a dietary component, to add things to our diet that have been shown in studies to improve either epidemiologically, either in populations, or in controlled trials to increase pregnancy rates. And two of these things basically come out of diet. One are polyamines, which people don't consume very much of in Australia. They're found in high quantities in fermented foods, and Australians don't like fermented foods very much. If you mention sauerkraut or pickled onions, then yeah, you might get a little bit of take up, but the rest of it, they're just not interested in. Adding fruit into the diet, which is decreased, especially citrus fruits, things like that for the polyamines, I think is incredibly important. I ask my ladies to have a grapefruit and an orange every day, and that will significantly increase the polyamine content. Polyamines help the eggs divide with even chromosomes, and that's something we see as women get older, that with the, for example, the increased incidence of Down syndrome, where you've got more chromosomes in one egg than there should be, if we can improve the ability of the eggs to divide evenly before the sperm goes in, we get an improvement in baby rates. And some of the animal data in putting polyamines back into diets is absolutely fascinating. So, gee whiz, adding fermented foods into diets which actually show an improvement in other health outcomes over time as well, given that may well improve your fertility, seems like a pretty sensible thing to do.
Yeah, I agree. It's great just to start early. In the fermented foods, we actually did a webinar on fertility probiotics in the microbiome and talked a lot about fermented foods.
Ah, yes.
Discussing, which I think, as you said, has ramifications across a lot of health aspects, but particularly for fertility. And they're things that I find if we can focus on the patients improving their quality of diet through what they can eat and what they do eat, instead of focusing on what they can't.
Yes.
It's a much better way of creating a healthier egg, a healthier person, than telling them what they can't and that they need to lose weight. So I find the weight loss can happen naturally by focusing on those good foods.
Creating good habits and being in control. And they are things that add obviously to not only people's better quality of life, but it helps their understanding. It also helps them stay in treatment until they get what they want, which is another thing. Now, the other thing that I think is really important in conceiving and helping egg quality are the isoflavones, which are also called phytoestrogens. And there's lots of people who want to jump on board in regard to soy products and say they're good, they're bad, they're this, they're that, and the other, which is all well and good. I've spent decades of my life looking at the effects of isoflavones on humans, and there is a lot of conflicting opinion, but there's not a lot of conflicting evidence, to be perfectly honest. The isoflavones hyperconcentrate, and these are really powerful antioxidants that are found in soy products, amongst other things like red clover. We don't eat red clover because we're not sheep. But they're found in soy products, and they hyperconcentrate inside the ovarian tissue and the follicular fluid, and the antioxidant effect is really protective for the egg, which is quite vulnerable to free radicals. And the consumption of 20 to 40 milligrams of isoflavones a day, which is either a single tablet supplement or you can find it in about 5 glasses of soy milk if you've got soy milk with isoflavones in it, that doubles background pregnancy rates. And in IVF cycles where they put some higher doses of isoflavones in as well, again, they see a concomitant doubling of pregnancy rates too. So I think those things as dietary additions are really quite positive. Anywhere we look around the world where fermented foods and soy products are consumed as part of the diet, we tend to see healthier populations.
Yeah.
And whether that's in, the Mediterranean diet, or whether it's in Southeast Asia or Japan, we know that these places have lower instances of, hormone-dependent malignancies, cardiovascular disease, etc., etc.
Yeah.
So again, positive things for health and diet, interesting things to eat, really. There's no point being blasé. Life, you get bored and get old, so you may as well enjoy some stuff and try some stuff as you go, but also improving your chances of conceiving and looking after your eggs.
Yeah. It's a better way to focus, I think. It's in having what you can have rather than having to lose weight, because that is a mental block for a lot of people.
Yes.
To be told you're too fat or you're overweight, you need to go away and lose weight. But I think it's hard to hear that people are told to do that without any hand-holding about how to do that. And I agree, as a naturopath, the focus shouldn't be on weight loss. It should be including the healthy foods, focusing on the healthy foods. We're just working on a program at the moment, Your Fertile Pantry, which is all about creating a fertile pantry, creating a fertile life, eating well, including the fermenting foods. And I do find that patients will naturally lose weight and increase their egg quality by doing that, rather than focusing on the weight loss as the goal and the outcome.
When we get to education, of course, the more educated people become, the better they can make choices that lead them to better outcomes. And, that's just a natural part. Whenever we look at anything that's not working particularly well in society, if we throw knowledge and education on top of that, we will generally get better outcomes.
Yeah. Well, fingers crossed we're helping to do that today and giving people that information. I think from what you discussed initially about the egg collection and the process of IVF will empower people to take their fertility into their own hands a bit and do ask questions of their specialists who they are seeing and get the right outcome for themselves, as well as the right dietary advice. And it's great to hear you looking at that alongside the fertility treatment as working in complement and in tandem to get the best outcomes and maximise IVF success for everybody.
Well, that's the point, isn't it? I mean, one of the problems we have with today's society is it's changing, and there's lots of people doing lots of different things, and we've got corporates, and we've got Donald Trump, and we've got fake news, and we really don't kind of know where to turn at particular times. So it's important to find people who are prepared to look after you and talk to you about what's going on and provide information and risks and benefits of different things, and then in the end ask them what they want, or present it in a way that they can understand. For example, IVF, which is obviously what we're talking about. I mean, I said to a couple this morning when they said, well, what if it doesn't work? And my point straight back to them was, pretty sure we talked about the best egg, and the best egg doesn't work most of the time. So if you're making an egg, only 3 or 4 times a year, that's good enough to make a baby, you're really looking on average at 3 or 4 egg collections to get an egg that makes a baby. And so really when you're looking at this, you're looking at a course. We're all hoping to roll a die and just turn up in a month where that egg's going to make a baby.
Yeah.
Okay, and if they do, fantastic, they're going to get what they want. But we don't know before people start. We can't tell ahead. So, we've got to actually go through the process and then look backwards.
I think one thing that I if there's one thing that's important to me, it's that the age of the woman or the age of the egg trumps everything else.
Yeah.
So if you're young, you've got the luxury of doing things sequentially. You can say, well, for the next 2 years, I'm going to get healthy and I'm going to see if that makes a difference. If you're 41, you haven't got the luxury of saying, well, I'm going to wait 2 years and make myself healthy and then I'll do IVF, because you're in that very steep bit of the slope where your natural fertility is dropping so rapidly that if you're older and you've suddenly decided that this is the time to start, you have to do these things at the same time. You can focus on your diet, but maybe at the same time you also need to be doing IVF, because if you wait and you do IVF at 43 or 44, your chances are so much lower that it's more costly. You have to do it more times. It's more psychologically difficult. And I often see people that I wish if only they had come and started IVF at the time they started all their other fertility processes, they would have been so much better off, and they probably would have been able to have not just a child, but maybe the second baby they wanted as well.
And hopefully we can help demystify the IVF process by today's webinar for people who are concerned, because I think you're right. People wait a long time after trying naturally before they see their fertility specialist or ask for more information. And I agree with yourself, Sonya. It really should be a process we start early and get a fertility workup, find out what's going on in there so we can address it nice and early and be prepared for what's ahead. And that seeing an IVF specialist doesn't necessarily think a fertility specialist doesn't necessarily mean you need IVF. There are a lot of things we can do to enhance the quality of the egg and the sperm here, as you mentioned. They play a minor role, obviously the egg being the major role. But I think the concern of a lot of people that we see through Conceive Baby is that seeing a specialist means I'm in trouble, I need help, and I'm going to have IVF, when it should almost be the first point of call to see.
I agree entirely. I have a lot of patients that come in and I say, look, we've done everything. It looks good. This is what I recommend that you do. This is how you time your cycle. This is the way you can go about it. And I say, look, we can always do IVF. You can come back at any stage. But in the meantime, I think you'll get there if we just focus on a few basic timing issues and a few basic lifestyle changes. And many of those patients conceive naturally without needing IVF.
Yeah, and that's great to hear. And I think we're great for people to be aware of, to not be scared of seeking professional advice and getting that workup that you talked about, and understanding their timing, understanding their eggs, and understanding if they haven't conceived within 3 months, they may not have produced that great egg yet. They may be getting their timing right. There is a lot of factors involved beyond just an egg and the sperm getting together that make things work or make things fine. So, is there anything you would like to end on to sum up for people today?
I think one of the really important things is we've been talking about seeing a fertility specialist, etc., etc. I'm going to be completely honest here. Look, I don't think everyone's the same, and I think it's really important that people try and find out a little bit about who they might be seeing in regard to their qualifications, experience and understanding. The problem with fertility treatments at the moment in Australia is there's a lot of algorithmic treatment. If you've got this, you need that, and that's it. That shows, I think, in many ways, a lack of understanding of some of the deeper requirements for the individual person. Yep. You know, I think there are a number of pressures around in society in regards to these particular things. So I don't necessarily have any advice for people how they do find out. The best IVF specialist is always the one that got their friend pregnant. Okay? So, you know, that's relatively straightforward. That's all well and good. It might not necessarily be the fact. We are dealing with people who are often very emotional and driven to try and get to an outcome, and they can be, you know, they can be in a state of mind that's relatively easy to accept things that may or may not be true because they want it to happen. So we need to be, I think we need to be a little bit cynical about what we hear from people, how it might be approached. There is a lot of information or a lot of opinion around, but be a little bit judicious about what it might actually mean and what it might mean for the individual.
I agree, and I've always said that the person who cares about your fertility outcomes most is you, ultimately. Yeah. Your fertility specialists are very invested, and some more than others, as you pointed out, and it's the same I find in my industry with naturopaths and natural fertility specialists. There are naturopaths, and there are probably naturopaths who do get the reputation that bring them down, unfortunately. So it's really good to take your fertility into your own hands, and we do have a lot of information obviously on the Conceive Baby website, and the reason for that is all of the people who provide that information are experts. So you do know that you are getting qualified advice, and make sure you do read the information, take the information, see what sits right with you, and not just, as you said, the friend who got my friend pregnant, I'm going to see them because that was the outcome they had.
Yes.
See what's right for you. And we did a webinar recently with Natasha Andreadis about genetics and personalised medicine. She went into a lot about that, about the differences in people and what is right for you. So I think that's a great note to end on. That make sure that you do make sure you get the advice that you are looking for. If something doesn't sit right with you, as Sonya went through initially, there are a lot of different ways to go about IVF. It's not just about putting an egg and a sperm together, and there's some are going to be more effective than others. So great to chat with you both today.
Thank you very much.
Thank you.
You'll also see both Dr. Knight and Dr. Jessup's articles on the Conceive Baby website as well. So please do jump over and check those out. They do have great information to provide. So thanks for being with us today, and make sure you join us for the next discussion coming up.